Hello, good morning, everyone. Good afternoon, or perhaps good evening. Welcome to the second webinar in the series when we discuss different aspects of the ENT procedures performed in local anesthesia. My name is Agnieszka Strzembosz. I am an ENT specialist and medical affairs director at Medtronic ENT. Actually, the ENT has a long tradition of the surgeries performed in local anesthesia. However, today it has a totally different phase. And when we speak about the ENT ambulatory surgical setting, we speak about the innovation. We speak about new technologies that make our procedures safer and potentially improve the surgical outcome. It is a great honor for me to welcome our keynote speaker today, our guest, Dr. Stephen Davis, who is the founder and medical director at Breathe Clear Institute in Los Angeles, California. It is really absolutely amazing opportunity to meet those guys who follow this innovation path. And Stephen is one of those here in US with the massive practice in sinus procedures and other ENT procedures performed in the local anesthesia. Stephen, thank you so much for accepting our invitation, and the floor is yours.
Thanks very much, Agnieszka. I really appreciate it. Thanks for that nice introduction, and thanks everybody for being here. I really appreciate everybody taking the time. As you were saying, whether it's nighttime or morning time or somewhere in between, it's really a pleasure and an honor to be here talking with everybody from around the world. So thank you all very much. So here are my disclaimers, and I wanted to say a little bit about my training. I completed my residency in 2005. This training that I did was primarily at the county hospital that you see behind you, this massive building. Was actually featured at the beginning of a show called General Hospital, a soap opera. It's no longer in use as a hospital, and they actually moved this place into a new building sort of set behind that building that you can't see. But this structure was so massive and had so much steel, they wanted to tear it down and do something with it, but they couldn't because it was too expensive to do that. And so it's just an office building now. But what we learned primarily in terms of an awake procedure there with respect to the nose and sinuses was just to do basically ablate the turbinates. When I was there as a resident, I think it was in my 4th or 5th year, powered instrumentation arrived, and we really could only use it in the operating room, and certainly there were no balloons. So then after I finished training, I started private practice. And what I did is I worked as an associate for 1 year with a guy in the community. And again, my main procedure there in terms of the awake sinonasal procedure, again, was turbinate ablation. So I just wanted to show you a picture of my office here, our office, because I could not do what I do without these amazing people around me. So just want to show you that. And then we'll move on to the operating room. So what's it like in the operating room? Well, obviously we have a lot of fun, hopefully, in the operating room, but it is an expensive place to go. And it's also inefficient. There's really often very long turnover time. And we're really, when you think about it, doing a lot of setup unnecessarily, given a lot of the sinonasal procedures that we're doing. There's a long recovery time for folks who need to have general anesthesia when they're there. But the good news is that it is an excellent place to get comfortable with awake procedures. Now, what are what I think of as 3 driving forces that have allowed us to get out of the operating room and into an office or awake setting? One is balloons, one is navigation, and one is local anesthesia, advances in each one of those. So a brief history of the balloon. The first generation of balloons required fluoro, and for some folks, at least in California, which I know is a very small part of the rest of the world, but we could not get, it was hard to get credentialed in using fluoroscopy. Plus, you had to put on a bulky vest, there was radiation, overall sort of uncomfortable. But then light, replaced fluoroscopy in the mid-2000s. And that's when I became a really committed balloon user and a frequent balloon user. And because of some quirkiness with reimbursement issues with respect to insurance and et cetera, I use this instrument in the operating room a lot. And I got very familiar and comfortable with it when the patient was asleep. So that was really nice. And then in 2014, we had balloon integration with navigation. And that was a significant advance in the technology. So image guidance. The first generation, if everybody here remembers, it was clunky. There were optical systems. You had to have these big trackers and things like the headpiece you see on that gentleman in the picture. It was uncomfortable. Those little earpieces, they kind of were painful in the ear sometimes. The machines had a large footprint. They were really designed for OR use and certainly too expensive to really even consider using in the typical office. But there are newer models now. There are no more uncomfortable headpieces, which is nice. And the footprint is smaller. They're more affordable, and the trackers are really slim and light. And for some instruments, such as balloons and shavers, the actual trackers are integrated, which is a significant advantage. So the second force in terms of getting us out of the operating room and into the awake office setting is local anesthesia. We've had really significant advances. And for a lot of us, this has been propelled by balloon use in awake patients because you don't have general anesthesia, clearly, when the patients are awake. Now, initially, at least when I started doing this procedure in the office, we were injecting. And injections are still fine. And certainly there are some situations where I do inject, of course, and I'll talk about those in a few slides. But for the balloon procedures, and basically for most all sinus work, I use topicals only. Now you can use the topicals placed in cotton or a pledget, and hello to Venezuela, or you can even use gels, and there are different kinds of gels that you can use, and you can have those formulated with your compounding pharmacy. Now for Eustachian tube dilation, I do some injecting into the cushion anteriorly and posteriorly of the opening of the Eustachian tube and into the posterior middle meatus as well. This is well tolerated, particularly after the delivery of the topicals. Also, benzodiazepines and acetaminophen can be helpful additions. So choosing a balloon sinuplasty system. Advances in balloon sinuplasty also. Learning curve for any system, of course. I think it's really ideal to be able to use the same system in the operating room that you're using with awake patients. The flow is just easier. You don't have to worry about memorizing the personalities of more than one system. And I just want to sort of establish that as I said before, I was a big fan of the lighted guide wire based balloon system. And I used it a lot, as I said. And the advantage of a lighted guide wire system, of course, is you don't have to set up any navigation. You don't have to set up a navigational system, which is an advantage. But the thing is, there are shortcomings. Well, there's shortcomings, of course, for every system. There's no perfect system for every patient. But in general, with the lighted guide wire systems, you have certain patients whose skin tone makes it challenging to transilluminate, or the thickness of the bone is challenging in terms of transillumination. For me, illuminating the sphenoid sinus has never been particularly satisfying. Also, if you have complex frontal anatomy, the wire can get placed in a spot where you don't want it, caught in a supraethmoidal, supraorbital cell, etc. So there's new vent technology, and that's what I have used. This is a navigated technology, and I really love that aspect to it. You really know where you are. The additional fact that the balloon handpiece is non-bulky, I really like that. There's a stiffness to or a gentle stiffness, I would say, to the balloon system itself. And that to me is actually an advantage. The initial system that I used had a really flexible tip, but I have come to really appreciate the ability to get that tactile aspect to it, especially as you use this system more and more and you kind of feel more comfortable with it. the gentle stiffness is a nice advantage that couples well with the navigation. Now, having said that, I do sometimes, because of that gentle stiffness, you may not get the exact perfect angle in an awake patient. And so I like to be able to use the Cobra if needed for my frontal sinus work, which patients tolerate really well. And also sometimes I just like to make the maxillary antrostomy bigger, and I do that if necessary, depending on the patient, with my standard instrumentation. So in addition to that, if you have a CT scanner in the office, the Medtronic system is compatible with in-office CT scanners. So we have this in-office CT scanner, so that works really well. That's really an advantage. And as I said, you can use it in both awake patients and in the operating room. Now the setup, there we go, okay. So what do we have in our office? And I'll show you a picture in a second. We have a tower, we have navigation, we have a microdebrider, a scanner, and a television to distract the patients. They can watch TV, and I'll show you that in a second. We have a powered chair. I strongly recommend, if you can, to get a powered chair that lays flat. This is money that I was reluctant to spend, but I did, and it was well worth it. I also recommend a full complement of Sinus Instruments. Again, that ability to just do what you're used to doing in the operating room and not have to remember that, oh, I didn't get that particular instrument. It's nice to have a full complement of instruments. And hello to Sri Lanka. Also, of course, in case of bleeding, you need an array of packing and hemostatic agents and some form of cauterization. And above all else, really, you have to have a staff that knows what they're doing, really gets into it, really motivated, well-trained. So here's a picture of our office. And you can see on the left in the background, we have our shaver. And in the next to the right is the monitor. And then next to that, we have our navigational system. And then on the right-sided slide, you can see there's a TV there, and patients can watch Netflix or whatever they want, and it's a nice distraction for them. You don't want to have the program be too funny or engaging for you so you don't get distracted. But other than that, it's a really great tool. There's also a small fan that you can see there in case it gets a little warm, just to get the temperature right. Okay. Now, so our setup is the Medtronic system. Why do we use the Medtronic system? I really went over this slide already. And I wanted to add, though, that it is cost effective. So selection criteria, let's talk about selection criteria. That's really important, right? So there are patient considerations. Patient considerations I would just break this down generally and loosely into age. So first you want to consider just approval. Like, is the procedure approved in your country for the given age that you want to do it on? In the US, the FDA clears things typically for, in general, over or under 18. So you want to first consider that. Then once you've established that, when you're thinking about the age of your patient, in general, our patients for office-based treatments or awake patients are over, you have to be over 14 in general. But of course, not everybody's the same, and you really have to feel your patient out. So for the young folks, often the patient's parent will have a very strong opinion about whether their child can tolerate something in the office or not. I find it to be very helpful to just ask the child, the young adult, how do you feel? How do you feel about doing this in the office? If you think they're a candidate, right? If you think they're a candidate, ask the patient. In terms of maximum age, there's no maximum age. And that's one of the real benefits of this technology. I've had several patients in their 80s and 90s who have, say, a fungal process going on in the sphenoid, and hello, Congo. DR Congo, hello. Well, we can get these patients taken care of in the office awake as opposed to needing to subject them to general anesthesia. That's a huge advantage. Another consideration would be the patient's sensitivity level. So I check that out during diagnostic endoscopy, and I make sure I use a rigid scope. The rigid scope is key here. You want to see how they're reacting when you have that scope, once they're anesthetized with some topical, how they're reacting. Now, if a patient says to you, I want to do this in the operating room, then that's a giveaway, right? You're going to go to the operating room. But if they're not saying, I want to go to the operating room, you need to be very thoughtful. And this is a skill that I'm still developing, always honing and trying to perfect, which is figuring out exactly which patients are going to be appropriate for awake procedures. Then, of course, your comfort level. It's not just about the patient, it's about how you feel. You need to feel comfortable doing what you're doing. And you need to consider your experience. And even if you figure you've done it 20 times in the operating room and you think cognitively that that's enough and you don't yet feel comfortable, don't do it. Take another run in the operating room. Hi to Bangladesh. So then you want to consider the anatomy of the patient, right? If you see a severe septal deviation, it's not always a deal breaker because it depends on where the deviation is. But again, do the rigid endoscopy during your diagnostic procedure, as opposed to the flexible scope, which can be sometimes misleading about how well you can access where you need to get to. Also consider a large concha bullosa if that's relevant, not necessarily a deal breaker, sometimes can be addressed or crushed with forceps in the awake patient, but just be thoughtful of that. Of course, you want to consider access for the Eustachian tube opening in particular, and I like to use a 30-degree scope during the diagnostic endoscopy to check access to the Eustachian tube. You want to consider your pathology, right? Mainly when I'm thinking about the sinuses, I'm thinking about ethmoidal disease. If it's severe posterior disease, then I do not recommend that in the office. And hi to Brazil, by the way. If you want to get into the posterior ethmoids and do a comprehensive, and need to do a comprehensive job, in my hands, that's an operating room patient. Similarly, if you have severe polyps and you really want to do a comprehensive job with the polyps and not just a debulking, debulking is fine. But if you want to be real comprehensive, then that's a better patient left for the operating room. With inverted papilloma, use your judgment, but especially if you need to be drilling at the point of origin, that's probably not going to be well tolerated in the office, at least in my hands. Consider severe nasal edema, particularly edema that won't resolve with prednisone. That can cause bleeding and problems with visualization. Not an ideal patient for the office in an awake procedure. And moving on, the procedures themselves. Let's talk about those. Turbinate reduction. I think turbinate reduction is a really good first awake procedure. Why do I think that? Well, it's, I'll tell you that in a second. It's a teaser to why I think that. But first, here's our setup minus the caudal. We have a scalpel, a caudal elevator, a 2mm microdebrider, and a Boy's elevator to outfracture. So in terms of doing the procedure, how do we go about it? What are just some practical things that just seem like they're just intuitive? Well, if you have a busy office and you just need to train your staff and you need to work on this yourself individually to make sure you just get through the basics, like getting vital signs, like getting a consent, like answering the patient's questions. Those are critical points, answering the patient's questions. With turbinate reduction, we do no pre-medication. I have the office staff placed tetracaine, big pieces of cotton, with tetracaine 6% and oxymetazoline 0.05%. The staff is trained to place those big pieces of cotton in the nose. Then I come in and inject the turbinates with local. And also I want to comment that the shaver you see in the upper right is technically not a turbinate shaver, but you get the point. I just want to have a visual up there. It looks pretty similar. So the procedure for me is really the same as what I do in the operating room. Of course, there are different ways of addressing the turbinates. I make my stab incision with a 15 blade. I elevate the mucosa with the caudal, and I like the 2mm blade, but the 2.9 is also an option. And then, much to my surprise, when I first started doing this, outfracturing is well tolerated. I then place for most folks. I then place a mustache dressing, observe them, and give them post-procedure instructions, which include saline irrigation starting the next day. And we also give them acetaminophen, 300 with codeine, and have them return in 6 weeks. Now let's move on to sinus surgery. So here are some of the instruments, the main instruments we use and have available in the office. And I don't use all of these for every procedure, but as I said, I think it's key to have them available. So we have our through cuts, both our up biters, down biters, side biters, back biters, our graspers, our cobra, the freer, the sinus seeker. I like to have the Hue visor, which is the second from the right, in order to get into the deep into the maxillary sinus if I need to. And then we have our balloons. There are 2 frontal sinus balloons in this picture. That's my favorite balloon. But anyway, so we've got also not shown here is the quad cut. I like the 4.3 millimeter, actually, a 4.3 millimeter quad cut navigated microdebrider. We use an array of scopes. My favorites for sinus work are the 0 and 45, but of course, the 30 and 70 can be helpful as well. And then you've got your navigated suctions, your sinus seeker, and the patient tracker seen in this picture. So when do I use balloons with the awake patient? In the frontals, always, almost always, right? Operated, non-operated, I always use this in the frontals. And I'm prepared to use the Cobra, and I like using the Cobra because it can be helpful to open up Agonazzi cells, remove small polyps, etc. With the maxillaries, if the patient's been operated on, I don't use it, but, and if they've got an open patent ostium, obviously I don't use it. But in the non-operated sinus, I always use the balloon as a starting point. And with the sphenoid sinus, again, unless there's a big opening there from an operated patient, I always use the balloon with the sphenoid. So getting into the nitty-gritty of the procedure, again, vitals, consent. I personally come in and ask them before I start, do you have any questions about the consent or about anything? Doesn't make a difference how many times I've talked to them. We pre-medicate with diazepam, mostly 5 milligrams. Again, the office staff will place those big pieces of cotton that have been soaked in local. Then I come in and I medialize the middle turbinate with the freer, and I place cotton that's been soaked in local in the middle meatus, and we wait again. And during that waiting period, will calibrate the navigational system. So then I use the balloon, and I balloon the frontals, the maxillaries, and obviously, if indicated for a particular patient, and ethmoidectomies. Now, then I move on to the sphenoids. And if I'm going to do the sphenoids, I need to put more local soaked cotton at the face of the sphenoid. Once we're done, we place a mustache dressing, even if they're not bleeding. Always place a mustache dressing, and we give them medicated irrigations to start using the next day. Again, give them the pain reliever and have them come back in 1 to 2 weeks, depending on what we've done. If we've done an ethmoidectomy, they come back in a week for endoscopy and possible debridement, and we give them 2 weeks if all we've done is ballooning. Eustachian tube dilation, the third procedure I wanted to talk about today. There's our setup tray. We've got the Medtronic Eustachian tube balloon. We've got a rigid angled needle, which I find to be very, very helpful for injecting. A spinal needle is fine if it's got the right rigidity, but I do like this angled rigid needle to get to the posterior middle meatus and to inject Eustachian tube cushions, opening cushions. In addition, we always will be having available not just the 0 degree, but the 30 and 45 degree scopes. And be prepared to outfracture the turbinates or do turbinate work if you need to. Outfracturing is going to create the least amount of bleeding in general. So if that turbinate is even obstructing a couple millimeters, be prepared to inject it and outfracture it. So the details of Eustachian tube dilation. Of course, always get vitals, always consent, always answer their questions, and always rule out a patchless Eustachian tube. What do? I ask them about epiphany. I have them sniff when I'm looking at the eardrum to make sure it's not moving around, make sure they can't hear their voice in their own head, etc. And we get an audiogram with temps that's valid for a month. So it's got to be within a month of the procedure. We don't pre-medicate with this unless a patient requests a benzodiazepine. And again, we have the staff do the same routine with the big pieces of cotton soaked in local. So then the key medialization of the middle turbinate with the freer, I put more cotton in there, including deep to the posterior middle meatus. And then I wait and do some injections with local. And so you inject in the posterior middle meatus and into the anterior and posterior cushions. And again, be prepared to address the turbinates. So dilating the Eustachian tube for 2 minutes. I use the 30 degree scope for visualization. Sometimes, if necessary, and this is not common, I will use a 45-degree scope for visualization that I put in the contralateral side of the nose. Post-procedure care, we recommend steroid nasal sprays, and the all-important letting the patient know that their symptoms may get worse, their ears may drive them nuts for a couple weeks, but that will get better. And we see them back in 6 weeks for follow-up and endoscopy. So here are some pearls. So in terms of planning pearls, just to recap and to add a couple, I really recommend getting familiar with the procedures in the operating room first. And this is kind of a key thing. I found that patients can tolerate no more than an hour of procedure time for a number of reasons. But basically, they just start to get squirmy and uncomfortable. And that's, I think, an important point. First procedure, turbinate reduction. As I said, why? Remember the teaser earlier in the presentation? Why do I think that's a good procedure? Because you've got it all. You have got bone crunching, you've got bleeding, you've got, some potential anesthesia dripping down to their throat and making it feel numb. And yet the procedure is really fairly straightforward, and everybody's probably really comfortable already doing that in the operating room. And for me, that was just a great way to start out. Then moving on to balloons, keeping it with simple situations, no major septal deviations, etc., picking the right patient. And then I like using questionnaires to track patients' progress. And also, if you're going to be doing these things with the awake patients, particularly with the potentially more bloody patients or bloody procedures, I meant to say, I would do it in the morning in case for some reason they need to come back. And then, of course, train your staff. In terms of pre-procedure pearls, we all know that patients, despite how involved in the conversation they may seem, they're not always hearing everything you're saying. They may not remember everything you're saying. And so I think it's really important to have handouts. I didn't always used to be a handout person. I don't like using paper unnecessarily, but I really find this to be helpful. And I think that developing protocols particular to the procedure is really important in terms of the staff training, et cetera. And these need to be in place before you start going into the awake situation. I cannot emphasize enough how important it is to frequently remind patients about not using blood thinners with the approval of the primary care doctor, of course. Having a ride home. These things are just really critical because patients might not feel like they're really having surgery. So they might not feel like they really need to stop the Plavix, it's that, or that aspirin, adult aspirin is a real significant thing. So starting with your talk with the patient and then moving on to the whole scheduling process with the folks in your office who are involved with that, constant reminders. Also, if you don't have a CT scanner in your office, if the scanner is off-site, make sure you have checked in advance that your images are loading into the navigational system. Ask your patients yourself, again, as I said before, do they have any questions? The protocols in wherever you might be around the world may be different, but in the US, we give them this consent. It's very scary. Our insurance company has us use these consents, and it's good because it makes patients really aware of what they're getting into and provokes a conversation for a lot of folks. But you really want to be able to reassure them of what they're getting involved with if these are minimally invasive, safe procedures. Procedural pearls. Talking to the patients is critical. For some of us, people like me have no problem talking. If you're the quieter type, or even if you're the talkative type and you're just a little bit nervous at the beginning, you need to talk to the patient. And I say this from experience. If you move the middle turbinate without letting them know that they may hear cracking noises, it's very trippy and potentially unsettling for the patient. If you say to them, you're going to hear some cracking now, it makes all the difference. And that's just critical. Telling them I'm going into the right side of your nose now. Now I'm going into the left side. Now you're going to hear crunching. Your throat might get numb. Your heart's going to race when we inject the local. All of these things, you cannot overdo it. You're not going to talk too much. Check in frequently. Beware the stoic patient who doesn't say anything. And you think, well, I've given them plenty of numbing and they've got to be doing fine, and they just seem like they're not saying anything, so they must be fine. Well, that's the patient who's afterwards is going to tell your medical assistant, well, that was the most painful thing I ever went through. Those patients may need more medication. So check in, you can always give them more local, inject if necessary. And again, as I mentioned, have your surgical instruments available. As I said, the numb throat sensation will resolve if that happens. And another pearl is if you medialize the middle turbinate and they feel it, you know you need to give them more topical. Post-procedure pearls. You can give patients acetaminophen before, or you can offer it to them afterwards. Of course, there's the benefit to pre-medicating. The benefit of offering it afterwards is not everybody really asks for it. And it's just a nice kind of connecting thing. If you say, do you need, was that at all uncomfortable? Do you need any acetaminophen? It's just kind of a connecting moment. And then we observe the patients. Of course, don't rush them out. Some patients need to be observed for a longer period, and we always make sure we have a room available for them to stay as long as they need to. And as the provider, I always recommend checking on them personally before you dispo them from your clinic. And it's a nice touch to call them the night of the procedure and just say, hey, how are you doing? I'm just checking in. So I wanted to say thank you to everybody. I really love speaking to everybody. It's so exciting for me to feel like we're all connected, all of us around the world. We need more of that. And thank you so much. And I want to invite everybody to come to Los Angeles, and feel free to watch me do these procedures, and we can have lunch or go to dinner and have a really nice time with both this and just talking and connecting and communicating. So again, thank you everybody for attending. And I guess we'll leave it to questions now.
Thank you so much, Stephen. I guess it was phenomenal. And thank you so much for sharing with us your very personal experience as a surgeon and as a physician in this specific situation. So again, to reinforce the message from Stephen, if you have any questions, please continue typing them in the question and answers panel or simply in the chat. So Stephen, this ambulatory surgical settings procedures is all about the details. Details about your competence, details about the setup, your staff, etc., etc. So the number of questions that come to your mind are quite specific. So you start so greatly about the training. Can we try to help those who are at the beginning of this journey to define their readiness to do, for example, sinus procedures and local anesthesia? Do you have any criteria that come to your mind, or some very specific guides or suggestions when you may say, okay, I'm ready? As
the provider, yes. Well, I would say that, first of all, when you're, well, the first basic step is when you're just super comfortable in the operating room. I mean, that's the first sign where you're like, wow, you always want to have that little bit of maybe fear in the back of your head whenever you're operating on somebody, of course. But when you're in that zone where you feel like, I'm really comfortable doing this. I've done 3 of these, 5 of these today, or whatever it is, or 5 this week, or 5, whatever level it is for you. That's the first sign. That's the first most important step. Then you want to think about your office setting and whether you have your equipment, right? You need to have everything you're used to having. And then you want to make sure you have the right person. You want to have a person who feels, in terms of your assistant, you want to make sure that person is comfortable doing this. They may be comfortable doing a lot of things in the office, but they need to be comfortable with the sight of blood. They need to be good with the patients. They need to have a lot of special qualities. So you need to have that person. And then, of course, you need to have the person trained. And in terms of the details of training, you just have conversations initially about what's important, what you're going to do. Ideally, have them watch the procedures in the operating room, or at least a video of it, so they know what's going to happen. And you start simple. And I could go on for a very long time about this, because there are a lot of different nuances. But, and I'm happy to, again, go over with anybody who's interested in doing this out there. I'm more than happy to talk to folks. But those are the broad strokes.
So it's very clear when one listens to you how much you care about your patients, how much you put the patient in the center of attention, how much you pay to the details of creating this safe environment. So the people do different things. Some people ask the patient to bring something very familiar with, whether it's a cushion, whether it's a famous book, whether it's a music. When you talk to your patients and plan the surgery, particularly the young ones, do you have any additional things that you add to make this sensational, healthy and safety environment, like allow the patient to bring its own music? I agree with the TV set. Just let you know, once I operated in the OR as a visiting surgeon, and they put on TV set the live stream camera from Maldives on the beach. I don't think it's a good idea. It was so distracting for us to see the people. However, there are things that are important for the patient. Yeah. So do you have any of those additional tricks?
Yeah, I mean, with respect, that's a good question, Anushka. I feel like there is a lot of folks like to use headsets, right? The pay for the patient. And my concern with the headsets is, well, if they ask for it and they want to do it, and some folks really like that, and that's perfect. But I like to be able to communicate and explain to them when they're going to be hearing certain things and feeling certain things. So that's why I prefer to have them have the visual stimulation with the music on or the TV show on or whatever it is. But I am cautious. I don't typically recommend to patients that they use a headset, but if they want to, then that's a great option for them.
Okay, so let's jump into very specific questions related to the procedures itself. One question comes probably from someone practicing in your neighborhood is, how can I do in a lay, how can I do a lay or local anesthesia for the Eustachian tube dilatation? And there are more questions. It's clear that you triggered the curiosity, how you inject the anterior and posterior cushions for Eustachian tube.
Yeah, that's a really good question. So I think the topical is important, right? The topical is really fundamentally why you're able to do this. And that may be counterintuitive, but the protocol that I was talking about with getting the tetracaine Afrin into the nose with a long piece of cotton, and then getting it into the middle meatus, injecting posteriorly to get those nerve fibers back there to get a kind of a block. And then once you've done that, you then move on to the cushion, and patients tolerate this pretty well. And I'm not just saying that cavalierly. Like when I first started doing this with some other products before we really had this down, I stopped doing it in the office because I wasn't injecting in the posterior middle meatus, and I wasn't injecting in the cushion, and we didn't have the topical protocol really down as well as we thought we did, and I just stopped doing it. And it's only until we got this protocol down that it became another option. And now I'm at that point where I'm like, I can't believe they're tolerating, but they really do. They really do. It just works. And that needle, that rigid needle, is key. In order to get it to where you need it. It can't be flopping around. You have to have a rigid needle.
Yeah, I think this time and dedication and the precision to do the good local anesthesia is key for the successful procedure. It's for the comfort of the patient. So another question. By the way, you received the excellent presentation, lovely presentation, and I love it. And I share the sentiments. Can we reduction inferior turbinate at OPD? How to control bleeding? May you share your pitfalls or hints? This bleeding aspect is usually a returning question, and everybody wants to listen to.
Why would that be? I don't have any idea.
Yes.
Well, first of all, again, going back to explaining to the patient that bleeding is normal. That is the fundamental thing, because they're going to have bleeding. I mean, that's just a given. I just feel really comfortable knowing that I can pack the patient's nose if necessary, and that will stop it. I have never had to do that. I have never had to cauterize the turbinates in the office. And I know that if I did enough of these, I reached a certain point, or we pooled everybody's experience, that of course somebody's going to have to cauterize, or with a bipolar, or touch it with a little suction cautery, or pack it. Of course that's going to happen, and you have to be prepared for that. But they're gonna have bleeding, and we use the mustache dressing, and they're gonna bleed, and sometimes the rare patient will need that changed every 20 minutes for a while, but that's just tolerated. And I mean, that's the best way for me. That's the best way for me to answer that question. Hasn't been a problem. I had one patient have delayed bleeding from actually a cryoablation procedure, and that was unusual and unexpected. But we really haven't had this be an issue. We just haven't. So.
Yeah, I think that this is, I once they had to fix the bleeding from the posterior aspect of the inferior turbinate, but basically by the compromising of the branches SPA, and then it can really, really bleed. Yes,
exactly. And I've seen that with, oh, sorry to interrupt. And I've had operated patients who I've taken to the operating room have turbinate bleeds, but for whatever, I guess it's just because you're not quite as aggressive, just sort of built in. I mean, I feel like I'm doing the same procedure, but maybe on some level I'm not being quite as aggressive in the office, and that may have something to do with it. Just maybe there's a small percentage in difference between how I handle that, and that's probably the reason, really.
Another question, thank you so much. How often would you have to perform an office endoscopic septoplasty, basically as a surgery of access, when you do the whatever? Mm-hmm.
That's a good question. I typically, for a simple spur, clearly, I mean, that can be done in the operating room, in the awake patient. I don't do a lot of endoscopic septoplasties. So because I just usually am making a hemitransfixion incision, and I just get sort of, I don't know, particular about being able to do everything I want to do with that septum. But I do do some work on the septum in the office. So I guess the short answer is, I will typically take a patient who's got any meaningful septal deviation that's not just a simple spur to the operating room. If there's a simple spur, I'll address it. That's very rare. Very rarely do I need to do that. But it's also because I'm selecting some of those patients out who have anything beyond just a very specific thing and take them to the OR. But I think I could do a lot more if I didn't have that sort of feeling with my relationship to the septoplasty. So that, depending on who's doing it, you could do a lot more of that, I think, in the office, depending on your comfort level with the septoplasty. But in general, I'm surprised at how I can get around most septal deviations. I think that is a take-home point, that with the topical and with some experience from the operating room, I am able to get to where I need to go for most patients, and it's even often surprising to myself, really.
Great, brilliant. Another great question. Do you have an experience in performing the same time the inferior turbinate reduction and balloon dilation of the Eustachian tube dilation? Yes,
I definitely do the ballooning first, if at all possible. I find that the phases of shrinking the turbinates to get back there would be your topical first. If that's not doing it, you can inject them. If that's not doing it, you can outfracture them. And then, which I don't think I have to do this much at all, microdebride them. You could coblate them, ablate them, cauterize them. But generally speaking, again, I will do the turbinates, yes, but afterwards, I think I'm answering the question.
Yeah. And I believe that, again, speaking about the critical details and a really good conscious inspection of the Eustachian tube orifice prior to the surgery and understanding how the opening runs, so you can consciously insert the tip of the balloon is absolutely mandatory and important. Another question, did you before laser inferior reduction, turbinate and dilation balloon sinus procedure? So it's about the mixture using the laser for the inferior and the sinus balloon.
I don't use a laser. I use radio frequency. And I just want to clarify, do I do both of those techniques simultaneously in the same patient? Is that what you're asking?
Yeah.
I will co-blade, or so basically I will use my main tool that I use is the shaver for adult patients in the office. I will typically, if I need to do touch-ups down the line, I will then use submucosal ablation. I don't typically use submucosal ablation and shaving in the same setting. Although I could, and I don't think there's a reason not to do that other than cost. And if you have a bipolar, that's a good way to do it. And I certainly think that is a perfectly good option to shave and then get your bipolar out and treat the turbinates. And that can also help with hemostasis as well.
Yeah. We are ending unfortunately to the end of the webinar. The one more question. You said you always use the frontal balloons for the procedures. Could you speak a bit more about that? Could you speak about more how we can make our frontal sinus identified as an additional anatomical landmark before we complete the full sinus? Yes, the sinus procedure is all about the anatomical landmarks that keep us orientated in the anatomy. One of the key things, at least in my practice, is that as soon as I identify the frontal, I'm gaining a really massive, big friend for me to make a complete sinus. So do you think that making the balloon dilation of the frontals can be an additional step to make the frontal your friend?
I couldn't, you stated that perfectly, really. Make the frontal your friend by using the balloon. Exactly. And then that's exactly the reason that I do that. I like to look up in there with my 45-degree scope, feel really comfortable with where I am, and then as needed, use my Cobra. So it's a great starting point. I think you really stated that perfectly, Anushka.
No, I love it. So maybe two last questions. One is about I think it's about the technique of the Eustachian tube dilation. During 2 minutes, how about the highest pressure you carried out? So it's probably for someone who would like to understand a bit more the technique and technology.
Well, it depends on the system. So the Medtronic system, it clicks into a certain pressure, which I believe is 12 atmospheres. For the systems that have a range of pressures, 12 atmospheres. Yep. But I could stand to be corrected on that, by the way. To tell you the truth, actually, it's 10 atmospheres of pressure. Thank you, Jeff. There you go.
12 for the sinus, yeah. I think what is important, this is a kind of 0-1 situation. Yes, that's probably what is important to say. It's not like with a microdebrider that you can have a different speed. And the last question, Dr. Davis, you have training course for dilation balloon procedure in US.
Yes, we did. Well, there are courses, that exist. And I know that I was trained on a variety of systems. And that, I mean, I can't speak to those. I don't know if you're asking if I personally have a course, which I don't. Well, I do, because you can always come to my office and I will teach you. So yes, there's always a course in my office.
Yes. Yes, exactly. I see here the Medtronic offers cadaveric trainings in the US as well, and the particular balloons. Stephen, my friend, unfortunately, we have to conclude. I think it was a really great 1 hour. I learned a lot, and I'm sure our audience as well. And thank you so much for being so open, so generous to share with us your experience that you gain through the years. And we know the surgery is the art, so you can't read everything in the books. So thank you so much for being with us today and speaking. Thank you for inviting our audience. We had a big group today, and usually it's really from all around the world. So have a great rest of the day. Thank you, Stephen, as well. And see you hopefully in the future, short in person. Thank you so much, all of you.
Thanks, Anisha. Thanks, everybody.
Thank you.